Hi, everyone, and welcome to my presentation on orthopedic screening for pelvic floor dysfunction. So the learning objectives for today are to understand common pelvic floor dysfunctions and also how to screen for orthopedic cases for pelvic floor dysfunction. A little about me for those of you who don't know me. My name is Emily Titus. I'm a physical therapist at the Lansdale Office Physical Therapy and Wellness Institute. I'm a Newman University DPT grad. I'm currently completing my OCS residency with IV Rehab and HSS, the Hospital for Special Surgery. I'm a current pelvic floor physical therapist as well as an orthopedic physical therapist. And in terms of my background for education on pelvic floor, I have only taken the Herman and Wallace Pelvic Floor Level 1 course. So only the female course, the basic entry level. I have plans to take all remaining courses in the future. So firstly, I think it's important to do a basic review of your pelvic floor anatomy. So here on the top picture, going down along the sides, you guys can all read the different muscle names. Your piriformis is, as we know, a hip muscle, but it inserts very close to the pelvic floor, so it's actually considered a pelvic floor muscle. Your coccygeus, pubococcygeus, and iliococcygeus are all portions of your levator ani group. Then you have your actual levator ani muscle, all of which are very important in sort of forming a foundation for your core, as well as obvious bowel function. Then you have your obturator internus, another hip muscle, but a common culprit in groin pain and pelvic pain. Then you have your puborectalis muscle. This one sort of helps with closing off the vaginal opening and assisting in closing bowel function. Then down here on the bottom picture, we have a superior view. So you're looking at the external anal sphincter, as well as your external urethral sphincter. You also have more of the superficial group of your pelvic floor muscles, your deep transverse perineal muscle, your bulbospongiosus and ischiocavernosus, as well as your superficial transverse perineal muscle. So all of these are considered your superficial group of your pelvic floor muscles. For obvious reasons, they're more superficial than are the levator ani. So firstly, I think it's important to talk about the incidence of pelvic floor dysfunction. It's actually very common. Nearly 1 in 4 women have some sort of a pelvic floor issue, and 1 in 15 men have some sort of a pelvic floor dysfunction, which I think is not quite accurate due to low reporting numbers, due to the societal stigma of men having any sort of pelvic floor issue. For obvious reasons, parous and multiparous women are at higher risk. So parity is just whether or not you've had children. So just because of the nature of childbirth and bearing children, even if you do not come to full term and miscarry, the whole process of childbirth and being pregnant is quite stressful on your pelvic floor muscles, to say the least. But fun fact, there is no change in risk for developing pelvic floor dysfunction, even if you've had a C-section. So there's no change in the risk between vaginal and cesarean delivery in terms of developing pelvic floor problems. So some common pelvic floor dysfunctions that we can treat as pelvic floor PTs in women are pelvic organ prolapse, or POP. There's 4 different types of it. Then there's also dyspareunia, which is painful insertion or intercourse. Then in men specifically, we have prostatitis, benign prostatic hyperplasia, and erectile dysfunction. So then in both men and women, what we can treat is urinary incontinence. There's 3 different types: fecal incontinence, as well as chronic constipation, amongst other things. But as I said, I'm limited by only having taken 1 course with Herman and Wallace. And that being said, I cannot treat men, so I'm speaking to only what I know, but I have not taken any further coursework. So this is a primarily female presentation. So in terms of pelvic organ prolapse, there's 4 different types, as you can see based on this photo here. So you have a cystocele, which is very common, where the bladder begins to fall out through the vaginal opening. You have an enterocele, where it's your small intestines that are pushing through. Then you have a rectocele, where it's your large intestines and your rectum. And then you have a uterine prolapse, where your uterus begins to drop. So the incidence for this is actually very common. Upwards of 40% of women have some sort of prolapse, and I can speak to that as being true. 1 in 3 to 1 in 2 of my patients, of my evaluations for pelvic floor dysfunction, I find that they have a prolapse, and most women don't know because sometimes it's not symptomatic. And there's different grading to it, but that's not important for this presentation. So the symptoms of pelvic organ prolapse are pain in your lower abdomen. That's very similar to menstrual cramping. Every woman will know that sort of a symptom there. Some women will report a feeling of a bulge or like a heavy feeling in their lower abdomen or bulging in their vaginal opening. This is one that ties very closely to orthopedic dysfunction. The very common symptom is low back pain or lower abdominal pain that worsens with standing, and it gets worse by the end of the day. For obvious reasons, since there's an organ pressing out through the vaginal opening, intercourse or insertion is typically painful. Then there's oftentimes a frequency increase and an urgency increase with urination, sometimes where they don't actually are not capable of putting out a lot of urine, where there's a feeling of incomplete emptying, where they go to void and they think they're done, and then they stand up and they're like, oh wait, I still feel as though I have to empty. This is because of the pressure being placed upon the urethral sphincter. Pressure on the urethral sphincter is something that is part of a pathway in your brain that shows when there's pressure there on that sphincter muscle. It's typically indicative that there's a full bladder of urine pushing downwards with gravity onto the sphincter muscle. So your brain gets a signal saying, hey, there's some pressure here. You probably should go void. So sometimes when there's an entire organ pushing down or part of your intestines pushing down, then your brain gets a signal saying you have to void, even though you don't, because there's no full bladder. It's just that there's an organ pushing down on you. So that sometimes produces an urgency where even though there's not actual much urine in your bladder, then you still feel like you have to go. And then sometimes if it's a cystocele where your bladder is falling out, sometimes there's a big kink in your bladder organ itself so that it can't drain appropriately. So that's why sometimes people will stand up after voiding and then be like, oh my gosh, I still have to go, because they kind of reset their bladder position. So the diagnosis for pelvic organ prolapse is typically made with an internal vaginal examination by an OBGYN or a urogyn or a pelvic floor PT. The treatment is typically very conservative at first, where they try to send you to pelvic floor PT, where a pelvic floor PT might suggest using a pessary or some dietary changes or strengthening. In the worst case and more aggressive measures are typically sling surgeries, where they will actually reposition whatever organ it is that's falling out or place a mesh that prevents further prolapse from occurring. But they're not particularly successful. In fact, pelvic floor PT has been found to reduce symptoms better than surgical procedures 12 months post-op. So that's an interesting little caveat there. So then we can dive into the different types of incontinence. So most people actually have a misunderstanding of what incontinence truly is. I can't tell you how many people have a script that says incontinence, go to pelvic floor PT, and then on the intake form, do not check off the incontinence box. So then I'll say, so what brings you in? Well, I'm not sure. My doctor says I have incontinence. And I say, okay, well, when do you experience incontinence? Well, I don't. And so then I'll ask, well, do you leak a little bit when you laugh, or leak when you sneeze, or leak when you squat? Oh yeah, all the time. I can't laugh without having to cross my legs. Or they'll tell me, oh, I don't have incontinence. That's what old people have, because I can control when I pee. So it's not an entire, like, I think people think that incontinence is just whenever your bladder fills, it automatically empties and people are just wet all the time, which is a misconception. So incontinence is simply defined as lack of voluntary control over your bowel or bladder. So it ranges from 45 to 55% incidence rate, with a lower reported incidence in men, as I previously mentioned, likely from the stigma of not reporting about these. So further on that, we have the first type of incontinence is considered to be stress incontinence. So this is where Like I said earlier, it's something that most people don't think is incontinence. But any sort of lack of control is not considered normal. And any leaking is not normal. It's never normal. People always say, "Oh, I just thought that was part of having kids, is I was just going to pee myself all the time." Wrong. That's completely incorrect. It's not normal. It's not healthy. It leads to all sorts of other problems. So stress incontinence is the inability to maintain enough pressure in your urethral sphincter muscles to prevent leaking of urine when an increase in intra-abdominal pressure occurs. So think about a sneeze, cough, laugh, if you squat, if you pick up a kid, if you pick up a box, that sort of thing. That's when leaking happens from stress incontinence. So the symptoms, as I already mentioned, those are all right there for you. It's leaking with different changes in pressure. And diagnosis is typically made with an OBGYN or a urogyn, and it can be treated conservatively with pelvic floor PT, amongst other things. And a new kind of next frontier sort of thing is experimental medications that have actually been found to be quite helpful in reducing stress incontinence. So then we have urge incontinence. So urge incontinence is defined as a sudden leaking of urine upon feeling the urge to urinate. So these are the folks that as soon as they feel they have to go, if they don't go within 30 seconds, they will leak. So in the pelvic PT world, it's sometimes referred to as overactive bladder or sensitive bladder. And I'll go into more detail about why here in a moment. The incidence is not as high because this is looking at purely urge incontinence. So oftentimes, I'll go into more detail later about mixed incontinence. Excuse me, oftentimes people don't only have urge incontinence, they have a little bit of both mixed stress and urge incontinence called mixed incontinence. So urge incontinence is typically a result of an irritated bladder lining that leads to contractions of the smooth muscle called your detrusor muscle in the bladder, where any urine that fills the bladder, suddenly that muscle feels like it has to immediately empty. So typically this is because something about that bladder is irritated, whether it's that you have an interstitial cystitis, which is a more complex diagnosis, or it's just that the bladder is so used to immediately upon filling at all, emptying. So sometimes people wear the just in case bathroom breaks of like, oh, we're going out to the store, but let me go first, even though I don't have to go, just in case I have to later, where it kind of trains your bladder that as soon as there's any urine in it, it has to empty, which is not true. You should be able to hold your bladder for typically, I think the average is like upwards of 3 hours, 2 to 3 hours, and you should be able to fill with a few cups of liquid. It's not just a few ounces of liquid that you can hold. Typically, it's upwards of 2 cups of liquid that you can hold in your bladder. As I mentioned, symptoms include frequency and urgency of urination, chronic UTIs from frequent trips to the bathroom, and frequent potential exposure to bacteria to your urethra. It can also come on with low back pain, groin pain, abdominal cramping similar to menstrual cramps, feelings of incomplete emptying. But the biggest thing is urinating way more frequently than what is considered normal. So normal micturition or normal urination should be between 6 and 8 times per day, including your nighttime. And then normal nighttime micturition is only once per night, 0 to 1 time per night, if you're under 65. And then if you're over 65, it's considered normal to go once to twice per night. The biggest thing to screen for is check meds, because oftentimes this can be related to medications and the side effects associated with them. So it might not be anything that requires a PT intervention. Rather, it's a discussion with their doctor about changing a medication. So here we have that slide of the anatomy again, mostly because here we see that all of the muscles down on the bottom photo, more of the superficial group of muscles, if they're in spasm, they're going to be pulling on your external urethral sphincter. And that can, as I previously mentioned, if there's any sort of pressure at that muscle, your brain interprets it as I have to go. So if any of those muscles are in spasm, it can falsely tell the brain that it has to go to the bathroom, even though it's just that there's a muscle that's really restricted and angry and kind of pulling on it. So PT in combination with meds for urge incontinence has been shown to be quite effective in reducing incontinence by upwards of 88% as referenced here. So then we have mixed incontinence. So like I mentioned previously, this is symptoms of both urge and stress incontinence. The incidence is anywhere from 20 to 55% of women. It's a very broad range. It's likely just because it's, like I said, it's such a misconceived sort of a idea that people don't think that they're incontinent, even though any instance of, excuse me, losing control of your bladder is considered incontinence. So this is, again, also diagnosed by an OBGYN or a urogynecologist. It's treated with meds, lifestyle changes, pelvic floor PT. It's just a combination of the previous two types of incontinence that I've already gone over. So in mixed incontinence patients, a study showed that pelvic floor PT is shown to be effective to reduce symptoms as reported by 71% of patients in that trial. So it's pretty effective. Excuse me, I think I've been talking a lot. My throat's getting dry. So dyspareunia, the next thing that I will talk about. It's kind of considered an umbrella term for any kind of painful insertion or intercourse. It's a very, very broad spectrum of different sexual dysfunctions that are all typically in one way or the other linked to an internal muscle spasm. So the big thing with dyspareunia, excuse me, let me get a drink here. The big thing with dyspareunia is that we kind of have to figure out why there's an internal muscle spasm that's producing the pain. So it can be because of, pulling a muscle, just like you could pull a hamstring. It could also be, and more typically is because of any sort of unfortunate past sexual trauma or sexual trauma in general. So there was a study that showed that, excuse me, both men and women, when testing, they put stim pads to surface EMG pads on your pelvic floor area, and then showed these people a series of car accident videos. So some sort of a trauma. All of these individuals with the surface EMGs showed increased tension in those muscles while watching a traumatic event. So even if it's not an actual threat, it's just a perceived threat, our muscles go into spasm or go into a restricted state. So for somebody who's had an actual past trauma revolving around the whole area of the pelvic floor, so a sexual trauma, sometimes it produces a subconscious muscle spasm, because just like you don't want to go put your hand back on a hot stove after you touched it and got burnt, you don't want to have another painful experience in that same kind of regard there. So it can produce muscle spasms there. So for these folks, I like to try and kind of take a team approach and make sure that if it's something from a past trauma, they certainly have a counselor on their team of providers trying to make sure that all aspects of mind body are being addressed. So these folks have painful use of tampons, pain with sitting because of those muscles pulling and spasm around your ischial tuberosities. They can have ischial tuberosity pain, pain with pressure to the groin. Sometimes these folks tell me that they couldn't get through the speculum exam at the OBGYN because they can't tolerate the use of the speculum, and certainly painful intercourse. So treatment can include medication depending on the type and mechanism of the injury, as well as PT and lifestyle changes. Here with pelvic floor. So then we have fecal incontinence and constipation. So these diagnoses can occur either due to a weakness of muscles or a restriction of muscles. So what I mean by that is fecal incontinence, similar to urinary incontinence, is typically a weakness of the anal sphincter muscles that they can't withstand the pressure of a potential bowel movement coming down the line to hold against that pressure. So that's when you then leak feces. So then constipation can be the opposite, where the levator ani muscles and the anal sphincter muscles are so tight, as well as the smooth muscles of the digestive tract are in restriction, where then it produces constipation. Where obviously you're trying to push against a dam and you can't get anything past. So these sorts of things can be treated with dietary changes, obviously, as well as medication and pelvic floor PT to make sure that we can address any muscular aspect of the diagnosis. So in folks that have fecal incontinence, it's been shown that PT has been able to reduce symptoms up to 75% in this one study that I referenced. And in another study below that, I noted that physical therapy has successfully returned constipation patients to normal bowel movements without the need for meds. So that's a pretty cool stat there. So then, as I previously mentioned when I was introducing myself, I unfortunately have not had the time yet to take the male coursework for pelvic floor dysfunction. So I cannot really talk too much about it just because I don't really know much about it yet. But many male diagnoses can produce an internal muscle spasm similar to female diagnoses. So it produces very similar symptoms despite having obvious different equipment down there. So just like I previously mentioned, both urinary and fecal incontinence will present similarly in men, as is constipation. So here's kind of the meat and potatoes of the presentation here, the connections to orthopedic diagnoses. So while I was presenting, hopefully some lights were going off in folks' heads when I'm talking about, okay, I have patients with pelvic organ prolapse that have chronic back pain that worsens by the end of the day and worsens with standing. What does that remind you of? It sounds like stenosis. It sounds like a spondylosis, that sort of thing. Groin and hip pain are very common if certain muscles in the internal, in the pelvic floor go into spasm, like your obturator internus or piriformis, things like that. And it can produce groin and hip pain that then does not respond to typical orthopedic physical therapy. So then it's kind of, okay, maybe this is something that is more pelvic in nature than just straight orthopedics. Sitting pain. Similarly, if you have a spasm, it can cause painful sitting. Most people would think, okay, well, what makes your pain better? What makes it reduce? Oh, if I stand up, it goes right away. Some people are going to think that's a bulging disc or a herniated disc or something discogenic, where if imaging comes back negative for those sorts of things, well, then why are they having this pain? It could be pelvic floor dysfunction. We all know about the different studies that show the huge connection between depression and anxiety, depression in particular, with chronic pain. Add in if somebody's unfortunately had to endure some sort of a sexual trauma, and it's the same sort of thing where if they have sexual trauma, which leads to dyspareunia, which leads to painful intercourse, that sort of thing. If they have depression going on as well, then they're going to have a more longer recovery road in terms of time, just because of how our body changes when we're depressed. So that's just something to consider. And then a big thing with incontinence is the increased risk for falling and leading to further orthopedic dysfunction, where if these folks, I had somebody a couple weeks ago who told me that they use the restroom upwards of 30 times a day and upwards of 10 times at night. I mean, if you're getting up and moving and going to the bathroom 30 times a day, that's going to increase your risk for falling. And especially if you're getting up in the middle of the night, this lady was in her 70s. If you're getting up in the middle of the night, if you're taking meds, blood pressure might be weird, if you can't see, if you have any sort of visual dysfunction, and then you're getting up 10 times a night to go to the bathroom, you might fall. And then God forbid you break your hip or have something happen in that regard that leads to further orthopedic problems. That's not good. So trying to make sure that we're addressing the pelvic floor aspect of things can really help improve the risk for falling and reduce the risk for further issues. So then if in an orthopedic physician's office or in an orthopedic physical therapy office, these are some important screening questions to ask, even not necessarily on the first day, because some are quite personal, but just something to consider in the back of your mind when you're thinking about the interview process with the patient. So if somebody on the intake form checks off incontinence, there's a dead giveaway. Or any sort of, I think our screening questionnaire has If either of those boxes are checked, that's certainly a conversation to be had. In addition to past surgeries, I've had multiple people come in with scar tissue or muscular spasm following hysterectomies. Men with a common male portion of that is a prostatectomy, things like that. If you are talking with somebody and they say, oh, yeah, I have 6 kids, like, wow, were they all vaginal? Or did you have cesarean sections? Like, how did that go? Oh, I had 6 vaginal deliveries. Well, as I mentioned early on in the presentation, multiparous women, so having multiple children, have a substantial increase in risk for developing any sort of pelvic floor dysfunction. So just something to consider if treatment is not progressing according to plan for an orthopedic problem, to consider if it's a pelvic problem. Especially if they tell you, oh yeah, I had 6 vaginal deliveries and I had, grade 2 tearing or grade 3 tearing, or I tore the whole way, or I had an episiotomy, or whatever, in terms of any sort of trauma during childbirth, even if it was just a traumatic childbirth in general, or if the baby was born breech. These are all things to consider because it's going to change how the musculature either repairs, if it's something that there was a tearing incident, or if the baby was born breech, it's going to stretch the musculature in a different way than it would during a typical presentation birth. And then in moving away from pelvic, just talking about, obviously, we all need to know the mechanism of the injury that's bringing somebody in, the chronicity, the ags and eases, the aggravating factors, the easing factors when it comes to pain, that sort of thing, where if somebody starts telling you, oh yeah, it's only as soon as I sit down, it hurts. And if they tell you, okay, like a common referral pattern for pelvic floor spasm is very similar to a sciatica presentation. Sometimes if one of the muscles in the pelvic floor is in spasm, it can produce unilateral posterior thigh pain just to the knee. Knobtrator internus spasm will produce groin and hip pain. It's a common referral pattern. Things like that, just to kind of consider when someone's telling you about their injury, or if they've had it for forever, if it just started after I had my last child. These are all things to think, could be pelvic in nature and not purely orthopedic. And then during conversation, I can't tell you how many people, when I'm stretching them or I'm making a joke or something, I say, oh my goodness, Emily, don't make me laugh so hard, I'm going to pee myself. Like, hey, how frequently does that happen? Because that shouldn't happen. Oh, I thought it was normal. It was just part of being a woman. No, absolutely not. We need to have a conversation about how potentially I could help you work with that and reduce that. And it could play into why you're having back pain, which is why you're here. That's a conversation frequently had. Or if during an hour and a half session with somebody for whatever knee pain or something, you note that they have to use the restroom 5 times. That's not normal. So that's a conversation to be had, and it might not be impacting their knee pain, but it could impact their risk for falling in the future and becoming a frequent flyer patient in that regard, or reducing quality of life from injury. So these are all things to kind of screen for. And then the big thing here is when to refer out. So if you're treating a patient and from a physician standpoint, if you are or a PT standpoint, if their imaging is negative, if they've had MRI, X-ray, CT, whatever, and there's no apparent structural deficit that would be producing their symptoms, and then they're trying pain meds and nothing's helping, or they're trying steroids, or they're trying muscle relaxers, or whatever pharmaceutical intervention they may be having that's not responding, or they're not responding to it and they're not seeing relief. If they're trying your standard orthopedic physical therapy bout and they're not seeing any progress made, their back pain is not getting any better, back pain, and they still feel a heaviness in their abdomen, it's likely not an orthopedic problem. Then if we've tried kind of all of the ortho approaches, then perhaps it's something pelvic. And then, like I said, throughout conversation, the benefit of us being PTs is that we spend so much time with our patients and have so much conversation that can really help point to a potential mechanism of injury or potential reason for injury. So if you're talking with somebody, and like I said, they say, oh, I have 6 kids, like, holy crap. Well, that could be why you're having some back pain, because all of those muscles that are down there that are strained by child bearing, let alone childbirth, they can refer pain to the back. They can refer pain down your leg. So that could be why you're having sciatica, but there's nothing on imaging. Maybe you should go talk with a pelvic floor therapist or consider seeing a urogynecologist or OBGYN or that sort of thing. So who to refer to? A female, typically I send them to an OBGYN just to get an internal examination done to make sure that it's not something, oftentimes different infections that are cleared up in a round of medications can present with urgency and frequency of urination, that sort of thing, or pain down there, that sort of thing. So I just like to clear that, hey, everything is good on the pathological front that an OBGYN can clear for. Or if it's something where somebody tells me, oh yeah, I thought, I didn't realize that having a prolapse was something that you needed to know about. Well, you're having back pain. Yes, it is, because it, believe it or not, it presents with back pain. Something like that, or if somebody is wildly incontinent, that might be somebody to send to a urogynecologist, where unfortunately the pelvic floor population, I can't tell you how frequently I would have patients come in and say, oh, I'm so glad I finally came in and was able to get some relief from my symptoms, because my first issue was, I said I went to my primary care and reported about my incontinence. And then my primary care said, that sucks. I can't really help you. Go see your OBGYN. So then I have to wait another few weeks to get into my OBGYN. My OBGYN says, yep, you're incontinent. I can't really help you unless you like a medication. Try going seeing this urogynecologist. They can better help you. So I have to wait another few weeks to go see a urogynecologist, only for a urogynecologist to say, this is a pelvic floor spasm. What we can do is we can give you meds or maybe try pelvic floor PT. So then they finally are able to get in to see a pelvic floor PT, at which point there actually is relief given by intervening in a physical therapy sense. But it takes so long and so many different providers that they have to go through and be screened by before they actually get any help. It's kind of like a underdiagnosed and overlooked population of patients, unfortunately. So that's why it's important as PTs, given, like I said, that we spend so much time with our patients, to make sure that we're screening appropriately to make sure that these folks don't have to jump through all the hoops of seeing this doctor, then that doctor, then this doctor, to finally see some change and some improvement in quality of life. So with men, you send them to a urologist typically. And like I said, I haven't taken the male coursework. There could be a better provider out there for men that I just have not learned about. But the big thing here is, in bold, you can send any gender to a pelvic floor PT for evaluation and leave it to the pelvic floor PT to refer out if needed following their assessment for them. So instead of having to jump through all of the various hoops, you can utilize direct access and send them to a pelvic floor PT to make sure that they're getting the best quality care. And then here are my resources for anybody who is interested. And I would just like to thank everyone for their time and attention. My email is the typical IV formatted email, emily.titus@ivrehab.com. If anybody has any questions, they're more than welcome to reach out to me. I'm always happy to answer anything regarding this subject. And have a great rest of your day.